Guys, this is Professor Rich, and I would love to welcome you to MedSurge. Adult Health 1 will be taught by me, Professor Rich, as well as Dr. K, and we are excited to get you guys started. Objectives that will be covered in this PowerPoint are medical surgical nursing competencies, cultural care, ethical principles, geriatric population and physiological changes, cancer the basis, substance abuse and dependence. We will not be covering obesity at this time. That will be covered later in the semester. Medical surgical nursing competencies include the nursing process. The nursing process guides the delivery of safe patient care and clinical decision making. We assess, we plan, we implement, and evaluate. Clinical decision making. There's quality and safety. In 2005, Robert Wood Johnson Foundation funded the project to educate nurses on safety and healthcare qualities. Quality and safety education for nurses, known as QSEN, has competencies as well. Those are patient-centered care, teamwork and collaboration, evidence-based practice, also called EBP, quality improvement, safety, and informatics. Patient-centered care. So patient-centered care is a benchmark that acute care facilities are evaluated against and focuses on. It focuses on treating patients and families with dignity and respect, involving patients and families in decision-making. Use effective communication skills, empathy, care, be compassionate. Patient-centered care is evaluated by several professional organizations. There's also evidence-based practice and interprofessional practice. We'll be talking about those on different slides. A little bit more about that patient-centered care evaluation. So there's an HCAP survey, Hospital Consumer Assessment of Healthcare Providers and Systems, again, HCAPS. And this is a standardized data collection from patients about their experience in the hospitals. The patients are provided a survey after discharge. And they're asked questions about their care. Do they feel like they were listened to? There's just different questions, and patients can voice their concerns or voice, that they're happy. There's also the Joint Commission. This evaluates a hospital. It's an independent, not-for-profit organization that accredits and certifies 77% of the U.S. hospitals. And this also publishes the national patient safety goals. And that's using medicine safely, alarms, preventing infection, identifying safety risks, and preventing mistakes in surgery. Evidence-based practice. So nursing care practices and protocols are based on the best evidence from research, studies, and clinical expertise. The steps of evidence-based practice include developing the question, which is commonly known as the PICOT, P-I-C-O-T. Then we search and collate the best evidence, evaluate the quality of the evidence, integrate evidence into practice, evaluate outcomes of practice change, and disseminate the evidence. Interprofessional practice. There's quite a bit of stuff on this slide. On the left side, you'll see just a bunch of different people who make up the interprofessional team. And then on the right, it's just the 5 rights of delegation for a nurse to be able to delegate. So interprofessional practice. We should provide patient-centered care. We should work in interdisciplinary teams and employ evidence-based practice to apply quality improvement. We should utilize informatics. Interprofessional education occurs when 2 or more professions, which could be students, residents, healthcare workers, learn with and about each other's roles. We learn from each other to enable effective communication. Sorry about that. Collaboration and improve healthcare outcomes. So the RN should be utilizing that ADPI, the nursing process. We have the UAP. They can complete patient care tasks such as vital signs, assist with ADLs. It's the RN's responsibility to monitor and delegate to the UAP. So the UAP is accountable to and works under the supervision of the registered nurse when performing the delegated patient care activity, but they also require ongoing monitoring. So if you ask your UAP to do vital signs and they don't, your shift ends and you move to the next, you pass on and the vital signs aren't done, it's ultimately on you, because as much as you delegated it, you need to follow up. You need to assess those vital signs. Our UAPs do not assess. Also, when you're delegating, pay attention to those 5 rights. Is it a right task? Is it a task that's appropriate for that person? Is it the right circumstance? Is it the right person? Is it the right communication and level of supervision? So just make sure that we're following those 5 rights when we are delegating. Cultural care. So culture, it's an integrated pattern of human behavior that includes thoughts, communications, language practices, beliefs, values, customs, courtesies, rituals, manners of interacting, roles, relationships, and expected behaviors of different racial, ethnic, religious, or social groups. It's the ability to transmit the above to succeeding generations, and it is very dynamic in nature. Cultural awareness, this is the realization and recognition that personal beliefs and values impact cultural health beliefs and potentially the view of those who are different. Cultural sensitivity, so this is an understanding, thoughtfulness, and kindness that leads to inclusiveness and equity. Cultural competence, this is the ability of healthcare providers to organize and effectively deliver healthcare services that meet the social, cultural, and linguistic needs of our patients. Culturally competent care means that the nurses learn about each patient and tailor nursing actions to the individual patient and that patient's needs. Bias. So bias is an opinion that is unfair or prejudicial in some way. There's implicit and explicit bias. So implicit is subconscious. It's visible through subtle behaviors. Conscious or explicit bias, it's blatant, it's purposeful, targeted, intentional, it's intended to cause harm. It's supposed to be negative. The person knows what they're doing. So we all have implicit bias, and that's something that we need to know that we all have. It is normal. There's been a million studies done, and it's just something that we all have, but we need to have our cultural awareness, we need to be sensitive, and we need to have cultural competence to not let that affect the way that we deliver our care. So what do we do? What do we say? So you have a patient that is Jewish and it's the day of their Sabbath. They are telling you that they need their head of bed raised, and you come in and you're like, well, just press the button and raise it. And they're like, well, I can't. So what we need to do is we need to go in there and help them. We need to do what they need us to do. They might need us to handle everything electronic. You walk into your room and your patient's very upset. They're Muslim. They have pork on their tray. They are, very upset. Remove the tray from their room. Call the dining hall. Get them a new tray. You have someone that's requesting, the husband's there, the patient's a female, and they only want a female provider. Get them a female provider, or do your best to ensure that they can have it. Make every effort you can. It's important to assess our patients for individual language needs and for healthcare providers to adjust their communication style to meet these needs. There's patients that have a limited ability to speak, to write, read English. If someone speaks Spanish, don't try to do your Spanglish. Get an interpreter. The hospitals have that. It's available. Most hospitals, especially Banner, all have the little screens, like the little iPads. Get that. It's not fair to the patient to try to understand what you're saying when they already don't feel good. They're sick. If a patient appears uncomfortable, introduce yourself. Explain what you're going to do and ask permission to do it. There are centers for culturally and linguistic appropriate services. That's called CLAS, and it focuses on respect and responsiveness. So respecting the wholeness of each individual and responding to each individual's needs, preferences, desires in order to provide services that reflect an individual's cultural and language preferences. Healthcare access. Not everyone has the same access to healthcare, and this can be because of various different things. So a few different things we'll go over. So disparity. This is a difference, inequity, discrepancy, or gap. A health disparity is a health difference that is closely linked with social, economic, or environmental disadvantages. Any difference in health outcome that is related to bias, injustice, exclusion, marginalization, and social determinants. So there's many different social factors. There's age, and this could be related to stereotyping, or this could be because I'm old, I don't drive anymore, and I need help getting to the hospital. Differences in education. Not all of our patients have high school degrees. Not all of them are there, so that they might need a little extra help with their health literacy. Someone can be disabled. Economic instability. The patient might have trouble from their day-to-day, living and scared to go to the hospital because they don't want to get that bill, or they can't afford to get to the hospital to begin with. Gender. There's gender bias that can have an end result of negative stereotyping. So an example is assuming all males who are transitioning to female act a certain way, and can lead to gender discrimination or unequal treatment of patients. Limited English proficiency. So patients with language barriers or poor levels of health literacy may use healthcare services differently compared to patients with a higher health literacy. They also could experience poor health outcomes. They're less likely to access healthcare. They might not access preventative services, like they're not getting their mammograms, they're not getting their flu shots. They're less knowledgeable about their chronic conditions, so they're less likely to go get help. They have higher hospital admissions and emergency room visits because they're not going to the doctor regularly to prevent these issues from getting worse, or they're non-compliant with their medications because they can't afford them. They may have limited social support. Mental illness is a big one. Race, sexuality, social isolation. So there's a bunch of different reasons that patients, have trouble getting access to healthcare. And it's not just the hospital. It's the big part of it's preventative medicine, because they'll come see me in the ER and I'm like, well, why haven't you been seen in 3 years for this? And they're looking at me like, well, I can't afford it, or I don't have a car, I can't get to the doctor's office, I don't have money for an Uber, I don't have a cell phone. So we need to be very aware that these are issues, and we need to educate our patient on these issues. We need to involve social work. Get them help. We have resources. So the best we can do is offer these resources to these patients. Okay, so we need to educate them on them, and we need to provide the resources that we can. Ethical principles. So we have, this is a fun little nurse in the making sheet I have here. So we have autonomy. So this is the individual's personal right to make decisions concerning him or herself. We have beneficence, which is acting positively on behalf of the perceived well-being of others, or you'll hear to do good. We have justice, and I'm sorry, my list is not in the exact order as the PowerPoint. So justice, this is fair and equal treatment for everyone, regardless of their race, religion, or gender. Fidelity, this is accountability to commitments made to others, to self, to the profession, based on the virtue of caring. Non-maleficence, so this is minimizing or averting harm. So this is avoiding harm. This also includes responsibility to maintain confidence and demonstrate moral courage with reporting. Veracity, tell the truth, refrain from misleading or deceiving. Confidentiality, so this is information is not shared beyond those who need to know. We all heard of HIPAA, correct? All right. During class time, we'll talk about some other examples of these. Ethical dilemmas. So I'm just going to quickly go through this list. So we have informed consent. So a patient must be fully informed by the provider responsible for a treatment or a procedure. Do not resuscitate directives. Patients have the right to refuse or accept life-sustaining treatment. Advance directives. This is a document signed to communicate the final wishes of a patient in the event that they cannot speak for themselves. Living wills. This is a legal document created by a competent person that provides the person's desires for medical care in the event that the person is unable to independently make decisions regarding care. Withdrawal of fluids and nutrition. So this is commonly referred to the healthcare agency's ethics committee for review and input. The decision to withdraw fluids and nutrition is not made lightly because it violates the responsibility of the provider and the nurse to promote comfort. Pain control. Nurses must be self-aware and vigilant against bias, organizational, or social pressure regarding the patients labeled as drug-seeking or hypochondrial, or any other factors that may inhibit sound clinical judgment and the provision to appropriate pain control. Genetic testing, reproductive technology, selective abortion. These are ethical questions that arise in the reproductive technology, and they're complex. They often revolve around religious values and legal issues. There's experimental therapies. These are ethical issues that arise when the right of the human subjects are examined. Do patients who have certain diseases have a duty to participate in a study even though they don't want to? Even if the results are going to help others, do they have to? Inability to afford prescribed care. So healthcare in the United States is not available to all citizens on an equal basis. Those who have health insurance or can afford to pay healthcare costs enjoy a level of care that may lead to a longer life expectancy and increased quality of life. Organ and tissue donation. There is a scarcity of There's a scarcity of donor organs, which creates an ethical dilemma concerning the allocation of scarce resources and who receives the organ or tissue. There is a great deal of fear about becoming an organ donor among people who have a general mistrust of the medical system. And how death is defined and determined. So I have heard that people are like, oh, well, you know, if you sign up as an organ donor and you might die, they may just not try to save your life because they want your organs. That is absolutely not true. But there are people who they're not in the healthcare field and they believe that. Geriatrics. Okay, I just want to say I'm pretty proud of my GIF here. GIF. I'll never know what it's called. Maybe you guys can educate me, but I'm pretty proud of it. There's a better one coming up though, you just wait. So, in geriatrics, there is normal decline and abnormal decline. We're going to talk about normal decline. So, there's senescence, and this is normal age-related changes in the organ systems. Sclerosis, which is hardening of the tissue due to fibrous tissue overgrowth. Stenosis, which is narrowing or constricting of a passage or orifice. You hear stenosis often with the spine. You'll hear it with other things as well. Atrophy, which is wasting away or decreasing in the size of an organ. And then calcification, which is calcium and calcium salts that are deposited in an abnormal location like blood vessels. So, common changes and issues with geriatrics. There's a lot. So, cardiac. There's heart and vascular disease, hypertension, coronary artery disease, myocardial infarction, and these are caused by sclerotic changes in blood vessels and heart wall muscle tissues. Heart failure. This is most often caused by MI or hypertension, so there's damaged heart muscle that results in decreased contractility and increases the size of the left atrium. Atrial fibrillation. Pacemaker cells in the atrium fire sporadically. This is resulting in a rapid twitching in the atria, backing up blood in the atria, which causes the inadequate filling of the ventricles. Heart disease. The risk factors for this include stroke, hypertension, high cholesterol, diabetes, smoking, obesity, poor diet, physical activity, respiratory, pneumonia. Older adults are at higher risk because they have a decrease in lung elastic recoil. They have a weakened cough reflex, weakened diaphragm strength. They have impaired swallowing. So they're at high risk for pneumonia. COPD, chronic obstructive pulmonary disease. For that, smoking is the greatest risk factor. Neurological, there's dementia, which is a progressive cognitive decline that affects a person's social and occupational functioning. Depression, it's difficult to diagnose in older adults and may include low energy levels, difficult sleeping, less appetite, aches and pains, difficulty remembering details. There's Parkinson's disease. This is a degenerative condition which primarily affects movement, causing tremor, rigidity, gait disturbance, and speech disturbance. Cerebrovascular accident, which that's a stroke, which is vascular disease manifesting as paralysis, weakness, speech, vision impairment. Other cognitive things, they can have episodic memory diminishing, evident in tasks requiring learning and recall of items that are not meaningful. For example, they can't remember phone numbers. Free recall diminishes, and this is the ability to recall unrelated words from a list decreases. Working memory ability decreases. Semantic memory may increase, and this is memory of facts and meanings, and intellectual ability are actually unchanged. Process speed can decrease, so it takes them a little bit long to process things. Renal, they're at very high risk for dehydration, and you will hear that several times throughout this class. The patient that's at the highest risk for dehydration is geriatrics. You will hear this again and again, I promise. So related to renal changes and they have a delayed and decreased thirst response. They have decreased excretion of medications and toxins through the renal system. So this could increase side effects. It can increase morbidity or mortality because they have a high risk for toxicity. Hyponatremia, which is low sodium, and hypernatremia, which is high sodium. And this is more evident because they have an impaired renal diluting capacity and concentrating ability. High and low potassium, this is related to GI loss and diuretic use. Their GU and reproductive system will have a general decline in bladder function and capacity. They can have sexual dysfunction related to hormone decreasing, organ atrophy, decreased sexual fluids. To just keep it going, for GI, we'll have delayed gastric emptying, delayed transport through the colon, increased acid secretion, decrease in liver and pancreas size. They're at high risk for gastric and duodenal ulcers, atrophic gastritis, gastroesophageal disease, reflux disease, which is GERD. They can have a vitamin B12 deficiency, anemia, increased feeling of fullness after a meal. They can have bone loss, constipation, fecal impaction. They're at high risk for diabetes. So we need to educate these patients on ways to prevent it, which include weight loss, exercise, and dietary limitations of fat and calories. So these patients are at high risk for diabetes, and we should teach them ways to prevent it. Nutritional. So they're going to have decreases in sense of taste and smell. Food may seem less appealing. They can have premature feelings of fullness, which lead to malnutrition, constipation, impaction, as I said. Dentition and chewing could be limited. We know a lot of elderly lose their teeth, so they end up getting, false teeth put in, but some people don't have the money for that, so they can't eat as well. They can have dysphagia, which is difficulty swallowing, which can lead to aspiration or pocketing food. Musculoskeletal, they can have decrease in muscle mass. Their tendons and ligaments become stiff. Their bone density decreases. They have increased bone loss. They're at high risk for falls. They have deconditioning. They can have arthritis, osteoporosis. They have limited movement and ability to perform tasks. They can have sarcopenia, which is a loss of muscle mass and increased body fat. Immune-wise, so they're going to have a generally diminished immune function. And we know that because when we think elderly, we're like, oh yeah, elderly get sick easier. Their skin has a decreased ability to function as a barrier. So they have blunted responses to infection as well. So the diagnosis to make that infection, or the way to make the diagnosis of an infection is difficult. They're less likely to have a fever. They're less likely to have elevated white blood cell counts or obvious manifestations of symptoms. When older adults develop infections, particularly urinary tract infections, sometimes the only sign that is apparent is a change in their behavior. They may not complain of pain in their bladder or spasms. They just all of a sudden their mood shifts. They have memory loss. They're confused or lethargic. They're acting very odd, bizarre. And sometimes that's a UTI and they have no other symptoms. But then when we run the urinalysis, we see they very much have a UTI. It usually looks like a sudden onset of delirium. They'll have a decrease in subcutaneous tissue, making temperature regulation less efficient. So we often hear elder adults saying, oh my God, I'm so cold, I'm so cold. It's because they can't regulate their temperature as well. Sensory. So they have a decrease in visual acuity. So if a patient can't see well, we consider giving them a magnifying glass so that they can read better. We want to speak to them rather than making them read. So you're not going to hand them like, oh yeah, here's your packet of discharge instructions. And they're looking at you like, they're hardly looking at you through their glasses telling you like, oh, I can't see this, I can't read it. You need to read it to them. You need to speak to them. Make sure the room's, well lit. You want a well lit room so if they're getting up out of bed, they can see, as much as they can. We want to make sure that clutter is removed from the area. Another thing, your patient's at risk for decrease in hearing. So they might ask you, I'm sorry, can you repeat that? I'm sorry, can you say that again? I'm sorry, can you face me when you say it? So they're gonna ask you several times to repeat what you said. Don't get louder though, just speak slower, clearly, and talk in front of them. Face them. Let them see your lips. Especially now that we're not wearing masks as of now. We'll see how long that lasts. But we're not wearing masks. Let the patient see you. Speak to them slow and calm. When you actually raise your voice, it increases your tone, and then they're less likely to hear you because they can't hear those higher tones. You need to be patient. Also, make sure your patient's safe navigating that environment. Again, clear the clutter. Consider occupational therapy for them as well. This GIF, I think it's so funny. I'm very mean. No, I'm not mean, but I still think it's kind of funny. She's fallen and she can't get up. Anyway, so geriatric safety issues. So physical safety, high risk for falls, safety of their home environment, driving, behavior problems in the hospital setting. Carefully review their medications. They might have side effects, dizziness, weakness, sleeplessness. These are priority. We need to review their medications because if they're on these different medications, they're already at high risk for falls. Then they're polypharmacy and they have medications that are causing weakness and dizziness or sleeplessness. And then they're getting up in the middle of the night. Well, they're going to fall, right? So it's priority that we review these medications. We need to educate the patient about fall prevention or educate family members if they're involved with care. So naturally occurring changes are in strength, flexibility, balance, the reflex time. All of them combined to put older adults at high risk for accidents and falls. If the home environment's not upgraded to compensate for the frailties of age, those can become risks of falling. So their bathtub, they should probably have like a non-slip mat in the bottom. They should probably have a shower chair. Decorative rugs, they're beautiful, but they're not very safe. It's very easy for someone to trip over them. They need their decorative rugs removed. Electrical cords, they can't be out and about in the room where they can trip on them. They shouldn't be climbing on step ladders or makeshift climbing devices. They shouldn't be doing this. So they need to get a chair in their bathroom, remove those rugs, remove the electrical cords from the center of the room. Make sure that they're, out of the way, out of sight, where they're not going to fall on them. Not climbing on step ladders. So, patients in the hospital, they're confused. What can we do? We want to figure out why, but what can we do to keep them safe right now? So we get a sitter or an observer. That's our best option. We can have them do busy activities, like maybe a busy apron, or, you know, some patients like to fold towels. Like if you have an elderly lady, sometimes you just give them towels, they'll just start folding them. Do the least restrictive and least invasive first. Avoid restraints. Avoid medication if you can. Try to get a sitter. Maybe that will calm the patient. Maybe now they have someone in the room and that's going to settle them. The big thing is least restrictive first. We don't want to, you know, tie our old lady down because she's confused. Maybe she just needs a friend. Medication safety. So again, polypharmacy puts our older adults at risk. It puts them at risk for delirium, for falls, side effects. They may not be able to access the pharmacy. They could have a bunch of open pill bottles and get confused on which one they already took. So we really need to educate them and their family on trying to keep them safe when they're taking multiple medications. Another big thing is abuse. Older adults are at high risk for abuse. This could be from neglect, this could be financial, it could be just physical abuse. We need to protect them, we need to evaluate, we need to look at them, we need to really pay attention to these signs. Cancer. So this is just going to be a quick, like, we're just kind of touching upon it. Cancer is a specialty. We do have to cover it, but we're not going to go super in depth. So cancer is a constellation of diseases involving malignant or unregulated transformation of cells within a specific body system. Although there are many types of cancers, all cancers are characterized by uncontrolled growth of malignant cells that compromise the integrity and function of normal healthy cells. The most common risk factor for cancer is the exposure to a carcinogen. Carcinogens are internal or external exposures that predispose individuals to DNA destruction, resulting in cellular mutation that may ultimately lead to malignant transformation of cells. Examples of some well-documented carcinogens are ionizing radiation, benzene, HPV, sun exposure, and tobacco. Cancer can present with a constellation of vague symptoms, including fatigue, significant unexplained weight loss, fever of unknown etiology, and night sweat. Some providers may describe these symptoms as constitutional symptoms, but this term is formal classification only in B-cell lymphoma. Patients may present with symptoms characteristics of a specific malignancy, therefore clinical presentation varies on the basis of the disease. These symptoms are related to the location of the primary cancer, the location of metastatic disease, metabolic changes associated with the malignancy, and the specific pathology of the disease. So if a patient's coming in and they're saying, I have a lump in my left breast, it's going to be a very different symptom than the patient that's coming in with suspected liver cancer has. So cancer is very wide range. So caution is the acronym that are used to describe the common warning signs. So C, a change in bowel or bladder habits. A sore does not heal. U, unusual bleeding or discharge. T, thickening or a lump in the breast or any other part of the body. I, indigestion or difficulty swallowing. O, obvious change in a wart or mole. N, nagging cough or hoarseness. So the caution, that is the big one for all, or not all, but most of the cancers. So a tumor can be benign or malignant. So a patient has a tumor, we're going to evaluate it. Is it benign or is it cancerous or malignant? So malignant and cancerous kind of go together. So benign. Benign tumors are usually slow growing, they're capsulated, they're non-invasive, they don't metastasize, and well differentiated. So if you look, you'll see that it is this perfect circle. I can't do a perfect circle, but that's a perfect circle there. So it's Capsulated, it's well differentiated. So you can tell this versus the normal cells over here. Now, if we move over here to the malignant, wow, I'm really bad at this. It's fast growing. It's not capsulated. It's kind of all over the place. It's invasive. They migrate. They're over here, right? They metastasize. They're poorly differentiated. So they're kind of like all over the place. There's a big difference between a malignant tumor and a benign tumor. Now, the best way to tell the difference, besides looking at it, is doing a biopsy. So if we look at something and we can't tell, is this malignant or benign, they're going to do a biopsy and look at the cell under a microscope and figure it out. Cancer progression. So carcinogenesis. The initiation and promotion of cancer involves a series of other molecular changes that occur after exposure to carcinogens. For this reason, not all individuals with known risk factors or known exposure to a carcinogen develop the disease. There's environmental, hormonal, and lifestyle factors, infectious disease, medications, immune status, and nutritional factors that are involved. Uncontrolled cell growth. So cancer cell growth and proliferation are unregulated by typical mechanisms. Altered cell differentiation. This is when a cell loses its expected structure and function. Metastasis. This is cancer cells replicate and expand locally into masses of cells known as malignant tumors. Cell-to-cell transfer is characterized by direct invasion into adjacent cells. So looking here at this slide, so in one, cancer cells in the primary site. So we have cancer cells, they're in the primary site, so right here, and then we have our normal cells over here. So now we go to 2. I really am bad at this. Cancer cells invade surrounding tissues and blood vessels and the lymph vessels. So here we have our cells and they are going down into our lymph. That's supposed to be an arrow. And now we come over to here. So cancer cells are then transported by the circulatory system. So they're in our blood and our lymph, right? So they're moving on. And they're transported to distant sites. So we're metastasizing, right? We're moving elsewhere. So cancer cells reinvade and grow at a new location. So now we have fully metastasized. This is bad news bears. So cancer staging. So this is important. The stage of disease is used to plan patient assessment, clinical management, and treatment strategies. The basic components are the tumor size, T, number of lymph nodes involved, N, and presence of metastasis. That's M. So T, N, M. Let's see if I can write this for you guys. It's probably not going to look pretty. T, N, yeah, this is bad. M. There we go. TNM. Let's know that. So again, so tumor size, our number of lymph nodes involved, and our presence of metastasis. So cancer is generally staged along a continuum of 1 through 4. So there's a small tumor without obvious spread outside the organ. This is a 1. Invasion of deeper tissue or involvement of local lymph nodes is a stage 2. Which you can also see over here. I have, it kind of goes through it right here. Larger locally invasive tumors are stage 3, and cancers that have metastasized are considered a stage 4. All right, so how do we prevent cancer? So there's primary, secondary, and tertiary prevention. So, in primary, there is risk factor modification. So avoid carcinogens, like cigarette smoking. Immunization, get your HPV vaccine, your hepatitis. Chemo prevention, and this is a primary prevention strategy for some survivors of early stage hormonal cancers, such as breast and prostate cancers. Looking at risk factor modification, just kind of backtracking a little bit. Avoid tobacco, limit alcohol, maintain a healthy weight, participate in regular, moderate to vigorous physical activity, eat a healthy plant-based diet, avoid processed meat, avoid charred meats, avoid high refined sugar, avoid sun exposure, wear sunscreen every day. So these are all very important. We need to know how to teach our patient how to prevent cancer. So they really should be, eat your greens, eat your plant-based diet. Don't be eating those charred meats every day. Avoid high refined sugar. Wear your sunscreen. Don't go out in the sun between, 10 and 2 p.m. Stay out of the sun during those hot primary hours. Secondary prevention. So this is essentially screening for early detection and management of the disease. Clinical outcomes are better for individuals that are diagnosed and treated for cancer earlier in the disease process compared to individuals diagnosed later in the disease development. Ideally, individuals with cancer-related risk factors should have access to non-invasive screening tests that can identify cancer in its earliest stages. When it can be treated effectively with minimal risk of reoccurrence, that is best. So screening for early detection. So secondary prevention. This is getting your mammogram, getting your colonoscopy, getting whatever there is to screen. It's your basic screening. Okay, so when I think of it, I think of mammogram, prostate exam, colonoscopy. Like those are the big things I think of. Tertiary prevention. So this focuses on reducing the morbidity and mortality once a disease has been diagnosed. So this patient already is diagnosed, but we want to prevent it from spreading and getting any worse. So that is the tertiary prevention. Cancer diagnosis and treatment. So diagnostics, so laboratory tests. Some lab tests can be performed on blood and serum, where others require a tissue sample, such as a biopsy. An example of another lab test, which is prostate specific, is the PSA test. We'll talk more about this a little bit later in the semester. And that's obtained via a blood sample, and it validates the presence of prostate cancer. Imaging. So imaging, this is radiographical, sonogram, other technology used to create images of the body for clinical evaluation. And they're effective in identifying tissue masses, which is one of the most common presenting signs of cancer. These imaging studies allow for the detection of these tissue masses that are undetectable on physical exam. So for example, mammogram, and then they find something, okay, we're going to do an ultrasound of it. Okay, now it looks normal, we're done. Or, you know what, no, it still looks suspicious. Now we're going to move on and we're going to do a biopsy. So biopsy is the primary method for obtaining samples required to determine the presence of cancer. It's a surgical method of obtaining a tissue sample for evaluation, and it's the most commonly used solid tumor evaluation. Endoscopy, so this is your colonoscopy or bronchoscopy. So these are performed with a rigid or a flexible tube, a light, and a lens that allow visualization of hollow tube-like structures within the body. So this is your trachea, your GI tract, and these could be necessary in order to access tissue for biopsy. Treatment. So the primary goal of surgical oncology is total excision of the malignant tumor and the local area of the potential metastasis immediately surrounding the tumor. Surgical oncology also includes debulking of tumor masses, and that's partially removing a tumor that cannot be completely excised. That sometimes happens with like pancreatic cancer. You need your pancreas to survive. Sometimes they'll remove a bulk of the tumor, but they can't remove any more of it because you have to have, that portion of your pancreas. Redirection of vital functions after tumor removal and reconstructive procedures are also components of surgical oncology. Radiation therapy. So this is localized delivery of ionizing radiation to intentionally destroy the DNA structures within malignant cells and induce cell death. Radiation treatment therapy plan is designed with the goal of maximizing tumor exposure to radiation while minimizing injury to normal cells. Antineoplastic medications are a broad class of chemicals and drugs used to treat cancer. So they're loosely divided into 4 different categories, which are chemotherapy, immunological therapies, targeted agents, and hormonal agents. We're going to just kind of leave it at that. And then we have transplant, which could be stem cell or bone marrow. So nursing considerations. So nursing care of patients with cancer crosses all subspecialties of med-surg nursing and ambulatory primary care. Because the disease can affect any organ system and can be managed in any clinical setting, we all need to be familiar with the basics of cancer. Patient problems are based on the types of cancer, such as, or the types of cancer, as well as the sites of metastasis, the stage of the cancer, comorbidities, and the therapy plan. Nurses providing care to patients with cancer should have specialized training in the management of specific antineoplastic therapy. So if your patient is on a chemotherapy drug and you are not certified or thoroughly have that specialized training on giving a chemotherapy drug, you are not to give it. Usually they'll have a nurse come down from the oncology floor and give the medication. You are not to give that medication unless you are trained on it specifically. So these patients, so basically our job on med-surg with them is to monitor and treat complications. So if your patient's coming in and they're on chemo and they're nausea vomiting, we're going to be treating that nausea and vomiting. We're going to provide patient education. Your patient may choose that they don't want to continue with their care anymore, and maybe they were on the oncology floor, and they decided, you know, I'm done with this. I don't want to do this anymore, and they got brought to your floor. We need to provide, you know, care for them. We need to educate them. We need to refer them to social work, case management. Maybe they need a support group. Maybe they just came in and they just got a diagnosis. They haven't even seen the oncologist yet, or they just saw the oncologist and they just got their diagnosis. You know, we need to be supportive. We need to do therapeutic communication. We need to, you know, let them know they're not alone and do everything we can to try to make them feel okay in those moments, even though, you know, a lot of times they really don't feel okay. So refer them to the support groups, get social work involved, talk to case management,